to start our live podcast and with Dr. Robert Murphy. Actually, this is Íris Brito, PRS Global Open Resident Ambassador from Lisbon, Portugal. There are few reports about the demographics and ambitions of plastic surgeon trainees, especially worldwide, and if this different between regions. So an international survey was administered by ICOPLAST to junior plastic surgeons from all 7 countries of the world. And to discuss this subject, I'm honored to be joined by Dr. Robert Murphy. And the recent paper, actually, Plastic Surgery Training Across 7 continents, results from the first global trainee survey. It's available now to read for free on the PRS Global Open website. Actually, Dr. Robert Murphy is a board-certified plastic surgeon, past president of the American Society of Plastic Surgeons, current president of the International Confederation of Plastic Surgery Societies, ICOPLAST, and the program director of for the residency in plastic surgery at Lake Valley Health Network. Dr. Murphy, welcome to the podcast.
Thanks, Íris. Thanks, Francisco, for having me.
Thank you. So I'd like to ask you, which were the main goals of this survey and how this study is different from other ones published in the literature?
Well, I think I'll start with the second point first. The thing that made this study different, it was undertaken by resident trainees from around the globe. And the point of the study is the fact that plastic surgery is a global specialty. And if nothing else, the pandemic proved that we're all connected much more easily now. But as we started to get more connected and look at education around the globe, we realized there's a tremendous amount of variability. And with that variability in training and the residents wanting to understand what that means, we figured that ICOPLAST, being an international confederation, would be able to give a line of sight to how different residents in different countries see their own training and how they would like to improve that training going forward.
That's really interesting. I think it's an amazing topic. Education nowadays in plastic surgery is very important, and see how it works worldwide. It's amazing. And actually, you get a lot of answers from different parts of the world, different countries, but actually there were some difference in respondents. Why you think like this happened? More European or more American or Asia? Why was that?
Well, ICOPLAST looks at the world as being divided into a bunch of different geographic regions. And with that, in each region, we have a trainee group that works with ICOPLAST. And in some areas, frankly, there's more interest than others. In some areas, the programs are more developed than others. And in some areas, the engagement is different. The connectivity engagement in Central Africa is certainly different than it is in Europe. So we did get representation from all the different, from the 7 different continents, as you said. We had about 1,100 trainees are registered through ICOPLAST, and we had about 300 responding during this. So we think we got a good insight, but by no means do we think we have all the answers to all the questions.
Sure. Francisco, do you want to keep going?
Yeah. So going on the back of what Íris said, I think it's been a fantastic study because we keep on talking about evidence-based medicine, and it's actually important to incorporate that into training. I wonder if you could tell us a little bit about what the difference in demographics were according to different regions in the world, and perhaps maybe focus on age or perhaps gender, and tell us a little bit more about that.
Well, again, the whole idea of this was how do we look at maybe being a global community of academic programs, and how do we come to some agreement maybe globally about what a standard training program might be, and part of that is certainly what the demographics are. So with that, globally the demographics were almost equally divided between male and female respondents, because different parts of the world show that their demographics even with that were different. So in North America and Europe, it's the number of women in training and the number of respondents were very equal, about 50-50. When you were in Asia or the Arab countries, the proportion of male to female increases. So there's always that subtext of that you have to be sensitive to about that. Also in some of the areas that we just talked about, like in the Arab world, the average age of the trainee was in the 30s, mid-30s, whereas, of course, in North America and the European nations, it's a little lower.
Yeah. And the other interesting thing I picked up from the article was that about a fifth of respondents were working elsewhere rather than the original country that they went to medical school. Why do you think that is?
Well, I think there's two things that usually drive that: is training and opportunity. So one of the things that the paper did show is that there are a perception of the trainees globally that they would very much like to train in a place that had very well developed training programs with a lot of operative experience and the exposure to as many subspecialties within plastic surgery as possible. So again, recognizing the fact that there's a great disparity among the continents and even within national societies within continents to be able to provide all those three. Folks that see their program lacking that are going to want to go somewhere else. And once you've left, of course, if you have a good experience and good opportunity, it's maybe less likely that you return home.
And we were actually discussing this just before the podcast, how it's very valuable to travel and learn through the opportunity of learning from different institutions abroad. One area in particular that I'm interested in, and I've tried to look at before, but I don't think there's been enough evidence out there, is how do you think the duration and the organization of training varies according to perhaps the regions of the world? Is there any specific things that change, or?
Again, it's very individualized. So even in the United States, for example, is that we have two different ways of approaching plastic surgery. Either becoming fully boarded in another specialty such as general surgery or ENT, and then doing 3 years of plastics after. That's called our independent track, or our integrated track, where we do 6 years within the scope of plastic surgery, with the front end being loaded towards general surgical experience. And then when you look around the world, there's different paradigms of that. The minimum amount seems to be 3 years, and then the maximum being 6, like we have in the States, with the average being about 5. Yeah. But obviously, if you're looking to standardize to some degree the education, because the education is presumed to be the base for quality, then we have to come to some agreement on what really that experience should look like.
The other thing is we have quite a varied crowd, and I find that perhaps that also reflects, in the UK where I'm from, there's different levels of research experience. So some people do a bit more research than others for choice. Did you find that in terms of the research that there was a difference whether the trainees wanted to do research before, during, or perhaps after their higher surgical training?
So research is interesting because it seems to be tied into two things. One is it's seen by many residents and trainees as a way of bettering their position, particularly if they have an academic interest. But the other thing that was very interesting to me is that research is very much found to be tied with the amount of clinical hours or free time. So in certain parts of the world, there's a great disparity about the average work week. So in Asia, for example, the work week is much more demanding than it is in other parts of the world. So with that, there's some degree of people wanting to achieve some balance between their commitment to the profession and their need for some free time or life outside the specialty.
Yes, we were discussing that topic, and I think there is really a hot topic nowadays about work and life balance. And I think there are also interesting conclusions in your paper about that. And there are also some changes, for example, in the US in the last years. And what do you think about that? Do you think you have a long way to improve? Are we halfway? What can be done?
Well, I think at least in the States, there's been tremendous advancements from the time I trained to where we are now, and certainly looking as someone who trained in our experience, there was a reason we called trainees in the United States residents, because years gone by we resided in the hospital. We hardly got outside. There was very little work-life balance. I don't think any of my co-residents in general surgery had any relationship survive. So clearly that's not healthy for anyone, and you can't be good for your patients unless you can be good for yourself first. So yet at the same time we're in a very demanding profession, so it's a balance that goes both ways. So I think the United States took some good steps in defining some arbitrary limit to provide a little bit of balance in defining how our trainees could function with their clinical duties and on call and the like. And I've seen many other nations do the same. But again, variability in how you approach that. And at some point, you have to work enough to become proficient and to become skilled. You shouldn't work so much that you do yourself or your family damage.
Yes, of course. And we could see also in the paper that holidays are also different, and that is interesting that the residents who work more actually are not those who have more holidays to compensate. So actually, what do you think also about this? And
it's
for rotations
that's a different, right? Because there's ways of assessing. There's ways of assessing some of this objectively, but then there's also cultural sensitivities that you have to build upon that. So to use objective data to generate a one form fits all in that is a little difficult. I think at the same time, being scientists, you can generate data to look at a normal distribution or Gaussian curve and say that yes, this is probably what is optimal for both of those, and given some cultural sensitivities, move a little bit in one direction or the other. We need to be harmonized. We don't need to be completely the same.
Yes, absolutely. Another interesting aspect was that 70% of the respondents, they would like to do at least part of the training abroad, like an observership or a fellowship. And I would like to ask you, how is ICOPLAST able to help them in this kind of situations?
Well, I think there's a lot of interest now, again, with globalization for national societies all over the world to try to make this happen. What most societies do as a national society, they either codify their own availability or they make it available for the world to come there, more as a pull phenomenon. What ICOPLAST can do, being a Confederation of Global Societies, is actually be the unifier, the world global clearinghouse, by being able to assimilate all that data and be a resource for trainees around the globe.
Great. And so do you think that nowadays residents are more interested to join their national societies and also international societies like ICOPLAST?
Well, I think residents see their national societies as a place that they can come for opportunity, because most societies are built in the tradition of education and service. So traditionally, that's where you've gone is to your national society. I think what's exciting to me, having lived through maybe the area where we've gone from a national perspective to a global perspective, is to see all the interest in the societies cooperating to make the experience both for the non-trainees, for the consultants and the people at my level, to see what's going on outside their own zone or their comfort level, as well as the trainees. I know that my eyes have been opened by being with friends from around the globe, as far as just their practice bases, their expertise, and knowing that, I know how much my trainees, for example, would benefit from being in other theaters where others are doing their craft in the way they've learned it and developed over time. So, I think the number of oceans we have between us no longer matter. We have the ability to visit. We have the ability to be virtual. We have the ability to podcast. So that's going to connect us more, and I think do our patients ultimately the best service, because young folks like you will be practicing soon and be able to draw on each other's experience to give the best quality care you can to your patients.
Dr. Buff, you have a wealth of experience, and you've held quite a lot of positions throughout your career, and this role that you have within ICOPLAST, and I guess to a degree within the article itself, I wonder whether you have any sort of advice for trainees coming up through the ranks as to what we should do and what we should focus on to try and improve what's been highlighted in the article.
So I think in terms of what's been highlighted in the article, it's all about education. And the thing, again, that makes this article different and exciting is the fact that this article was the work of trainees. And the trainees were very enthusiastic. They want to make their lives better. They want to expose themselves more. So I think at the very core, for a trainee to become passionate about what's important to them, whether it's global education, whether it's becoming more exposed to a certain part of the specialty that they want to practice, I think that's the key. And I think even with regard to leadership or advancing in societal ranks, again, it's carrying that passion through, being able to do a good job, and to also to be able to be available, to share your expertise, and to be able to grow that connectivity. Because the more you build and the more you're seen as being a constructor, the more people have faith in your product, and the more people would value your experience and your contributions.
Yeah, definitely agree with that. I think we have a few residents in the crowd. I don't know if anyone wishes to bring up any points or any questions. By all means, go ahead. There's a microphone back there.
Hi, great talk. Stav Brown from MSK, New York. So I was wondering if you have any advice for ASPS or PRS on things that these organizations can do for plastic surgery training to advance it. It's something that can be done globally for everyone. Thank you.
With regard to training, so I think I think there's a lot of interest in trying to do that. I just came from the academic chair meeting upstairs, and part of what they're doing is looking at what the American society can help to do to spread the word. But I think to the point we made a little earlier is how can we bring the globe of all those nationally based interest groups together, and hopefully that's someplace that ASPS, given its international presence with the Global Leadership Forum or ICOPLAST, by virtue of having so many international societies represented, can facilitate going forward.
Yes, absolutely. The journal as well, PRS and PRS Global Open, actually opened the resident advisory board some years ago. When I joined in late 2019, beginning of 2019, I was the first European. But then, if you look at every quarter, there are a lot of people from all over the world. So really, I would like to invite every resident from America or from any other continent in the world to join the journal and be active, because we are a family, and you are really welcome anytime.
Lovely. I don't know if anyone has any other questions that they would like to ask. I wonder, perhaps I'm just going to divert the questions from Dr. Murphy to Íris. Perhaps you can tell us a little bit about your experience and any thoughts on the.
Yes, actually, Portugal is going. If I talk about Portugal, it's going. For example, when we talk about gender, it's going in line with the paper. We are around 40% of females. We have a full 6-year program that includes 1 year of general surgery and then 5 years of plastic surgery. Residents are allowed to go abroad and do rotations or fellowships, and that is included in their program. So that is a really important aspect. We can stay at least until 1 year abroad. I spent 7 months in different continents. So actually in the US, in Asia, in Taiwan, and in Europe. And I think it's really nice to have this kind of interaction. And regarding publications and research, it's recommended but not mandatory, so people who are more involved in university hospitals or would like to do a PhD will follow this path. But I think this could be the main aspects to know about Portugal. Do you want to tell something about your experience also in the UK?
I guess I could. So in the United Kingdom, it's all these things go hand in hand. In the United Kingdom, it's recognised as one of the longest training pathways, and there are pros and cons like anything else. But like we have a curriculum, and we're not necessarily encouraged to go on fellowships, but the majority do go because I think it's an invaluable experience you get from those. Likewise, on the same note, we have a national society, and it's sort of nicely introduced in the article, which is called PLAST. And over the last decade, and perhaps even more, they've been doing remarkable work to collate data and sort of to advocate for plastic surgery trainees in the United Kingdom. And that's, when national trainees when trainees come together and you're able to sit at the big table with the people that dictate the curriculum, you actually gain quite a lot of power. And we've been able, the PLASTA organization has been able to create a curriculum, teaching, and on the last point, it's been able to highlight a lot of diversity issues, which I think nowadays, and it's been important for most of the time, they've highlighted a lot of equality issues and sort of time. So if you're female and you want to have time off training, how can we support you? Especially if you're pregnant, and how can we best support you for you to come back to work? So there are a number of things that national societies can do. And to Dr. Murphy's point, I think the collaboration of national societies at the end of the day comes together and hopefully represents the interest of all of those that are here present.
I would like to make one question. When we noticed in the study, only around 10% of the respondents were American. How do you think we could get more Americans involved in ICOPLAST training or surveys?
Well, I think there's a little bit of comfort in North America about training programs, and people in the U.S., my trainees, tend to look at ASPS first. And when you sit here at an ASPS meeting, there's obvious reasons for that. But at the same time, my trainees are multicultural, and we've talked about international a lot, and we've had an experience where we would send trainees to Haiti. Because of unrest there, that was stopped, but now we're looking at sending them to Pakistan. So we embrace, the global nature of our specialty. But I think it's in the U.S. What'll take a little time is to see icoplast be as visible at the training program level as ASPS, which has traditionally been our gold standard.
Brilliant. On that note, I think we thank you, Dr. Murphy, for giving us your time and being able to debate this article that's available on PRS Global Open. I would like to thank everyone for their time and remind everyone that please subscribe to the PRS Global Open Resident Series podcast. And yeah, thank you very much, everyone.
Thank you very much.